Hello, I'm Dr. Joel Morgenlander, and with the help of Dr. Jessica McFarlin, we have created this video for you to review the core neurologic examination. Neurological diagnosis starts with patient history, followed by physical examination. You may be performing a neurological examination as part of a complete physical examination, or if your patient has a neurological complaint, neurological localization and generation of a differential diagnosis will be the key to your successful evaluation of the patient. Regardless of the reason, it is important for you to feel comfortable in how you are performing the neurological examination. Without your clear understanding of how to go about this exam, your ability to gather clinical data and synthesize that data into an appropriate hypothesis will be compromised. Some aspects of the neurological examination are more reliable than others. This may vary between patients due to the subjective nature of the tests, or may vary between exams in a given patient due to differing levels of cooperation. Our goal in this video is to demonstrate the core neurological exam and show you which aspects of the exam are the most reliable. Depending on the patient complaint or physical findings, you may wish to expand on this exam and perform a more detailed examination in one or more areas. The core neurological examination is broken down into mental status, cranial nerves, motor, sensory, reflexes, coordination, and gait. We suggest less experienced clinicians perform the exam in this order. With more experience, you may find another way more efficient while maintaining all the elements demonstrated. Feel free to refer back to any or all portions of this video to review the neurological examination. Just click on the section you wish to review. There may be alternative ways to perform aspects of this exam. We demonstrate a standard approach that we use in practice. Thank you for your attention. This is Dr. Jessica McFarlin, and Dr. McFarlin has helped me to create this video for you on the core neurology exam. The neurology exam starts with the mental status exam. If you're doing a general history and physical examination for your patient, you may not need to do any specific mental status testing, assuming the patient gives you a good history. If more detailed testing is needed, we recommend you check at least 3 areas. Make sure the patient's oriented, check their language, and memory function. You need to know that your patient is oriented to person, place, and time. For language function, you can check naming and repetition. Have them name an object and a part of the object. If you have questioned whether that was done well, try a second object. For repetition, have them repeat a simple phrase back to you. For memory, have them register 3 objects, and at a later time during the exam, repeat them back to you. If you have some concern and want to do a little bit more detailed testing, you can have the patient spell world forwards, and then have them spell it backwards. Spelling worlds forwards and backwards is a very good test for screening for cognitive problems. If you feel more in-depth testing is needed at the bedside, we would recommend the Folstein Mini Mental Status Test. But just understand that that test is not perfect, and patients can have cognitive dysfunction while scoring highly on the Mini Mental Status Test. That really completes the mental status exam, and now you're ready to move on to the cranial nerves. Now we're on to the cranial nerve exam. There's no need to check cranial nerve 1 in a routine exam. If the patient has a complaint of trouble smelling, you may choose to check smell through using a non-noxious stimulus. Cranial nerve 2 should be checked. You're going to want to check pupillary response, visual fields, and fundoscopic exam. However, if the patient has a complaint of blurred or altered vision, you start by checking visual acuity. Usually, you'll have a card, like a Rosenbaum card, to use at the bedside, or a Snellen chart that's on your wall. Ask the patient to hold the card and cover one eye. And then pick a line that you're pretty sure the patient's going to be able to read and have them read down the line. It's okay if they make a mistake. Try and push the patient to read lines that are lower and lower, improving their testing. If you have the impression that a patient should be using glasses and they don't have their glasses, consider taking an index card and popping a small hole in the card, then have them hold that over their eye they're using to read, and you hold the Rosenbaum card for them to check their acuity. That will help with refractive error. The next is to check their visual fields. It's important to check one eye at a time because if a patient has a monocular visual field problem, you can miss it if you check both eyes at the same time. I usually cover the patient's eye with my hand and ask them to tell me how many fingers they see flashing in each of 4 visual fields.
1, 2, 1, 2.
And then repeat it with the other eye. If you have the impression that there's a visual field defect, you may want to map out the visual field deficit. Once again, cover their eye and ask them to tell you when they see your finger wiggling.
Now, 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 now.
I wouldn't do that routinely, but would do it if you feel there's a visual field deficit. Next is to check the pupils. You're going to want to check with a bright light, and you can either use your pen light or use the ophthalmoscope as I'm doing. Make sure you have the patient look off into the distance so they don't converge. Then check one eye and look at the other eye and swing the light back and forth. You're looking for symmetry of the pupils. You're also looking for direct and consensual response. And when you swing the light back and forth, you're looking for a paradoxical dilatation of the pupil, which would suggest an optic neuropathy is present. If you see asymmetry in the pupils, you're going to want to turn down the lights in the room so that they can maximally dilate. Then recheck with your light, direct and consensual responses, in the light and the dark, and look for the biggest asymmetry. Remember, small pupils sometimes suggest sympathetic dysfunction, as can be seen in the Horner syndrome, and then the patient may have mild ptosis along with that. A very large pupil would suggest parasympathetic problems, and you may see signs of third nerve palsy such as significant ptosis. If the pupil is just dilated, it could be that they use some eye drops to cause that. Ordinarily, you're going to check a fundoscopic exam next. For the purposes of this demonstration, we're not going to dim the lights, but you need to feel comfortable with how you go about doing the fundoscopic exam. In general, you're going to use your right eye to look in the patient's right eye. Be comfortable. Make sure you're at the right height to examine the patient. I like to have my hand like this on the ophthalmoscope so that I can put it against the patient's cheek in case they move, but also ensure that I'm very close to the patient. Look for the red reflex and come closer at the eye, and then try and follow the vessels to the disc. Remember, you're looking at the optic disc for color and pallor. You're looking at the cup to disc ratio, and you're looking to see that the edges are flat. Then utilize the vessels to follow the vessels out into the 4 quadrants of the retina, evaluating the retina and the vessels as you go. Next, we're going to check cranial nerves 3, 4, and 6 together as we do eye movements. Have the patient look at your finger and make a big H with your finger, looking all the way to the side, up, down, back over, up, and down. Remembering that it's cranial nerve 6 that moves your eye laterally, cranial nerve 4 that moves it down and in, and everything else is cranial nerve 3. That's the eye movements. For the trigeminal nerve, we only check for facial sensation. Checking masseter strength is not a very useful thing to do. I like to use a Q-tip that I have in my office. You might use your finger, but some patients feel uncomfortable with you using your finger. Check V1, V2, and V3 and ask them to compare side to side for light touch. Does that feel about the same? If you have any concern that it's not equal, get a sharp tip from breaking the stick and compare sharpness. Is that about the same on both sides? We're always comparing side to side. Some patients will try very hard to tell you about subtle differences. That's not what you're looking for. Now we're on to cranial nerve 7. On the screening exam for cranial nerve 7, all you really need to do is have the patient smile. If the smile is symmetric, you can usually stop there. If there are concerns about facial weakness, then go on to do more detailed testing. Have the patient wrinkle their forehead. Then have the patient close their eyes real tightly and bury their lids and try and open their eyes. You can tell the patient's trying if you see Bell's phenomenon. If their eye doesn't roll back up, then they're not trying hard to squeeze their eyes as tight as possible. You can have them blow out their cheeks and hold the air in their mouth. That's another way of checking for lower facial strength. For a screen of cranial nerve 8, you can either check a finger rub or whisper in the patient's ear and ask them to repeat. Sometimes just rubbing your fingers, such as this, and asking if the patient hears you is good enough as a screen. If you think there's a problem, you may want to compare air conduction to bone conduction with your tuning fork. Now we're on to cranial nerves 9, 10, and 12. Part of your screen for those nerves was to listen to the patient's speech and see if it was slurred. Basically, you're going to check and have them say ah and look at their pharynx and tongue and check their tongue strength. You can use your ophthalmoscope or your pen light, have the patient open up and say ah, look at both sides of their pharynx, make sure it's symmetric as it elevates, and then have them take their tongue and stick it into their cheek. Have them push against resistance. If you check this against all your patients, you'll know what normal feels like. Look for asymmetry. For the 11th cranial nerve, have the patient turn their head into your hand against resistance and then back the other way. Then have the patient shrug their shoulders. Try and push down. Look for asymmetry. Now you've completed the cranial nerve exam. Now we're on to the motor exam. Before we start the exam, remember what you're after here. If the patient complains of weakness, you're looking for the pattern of weakness. In an upper motor neuron lesion, the patient will be weaker in the extensors of the arm and the flexors of the leg. If the patient has distal weakness, they may have a neuropathy. Proximal weakness is most commonly seen in muscle disorders or myopathy. Ask the patient to get in a gown so you can inspect their muscles. You need to look for atrophy and fasciculations. You're going to check tone in both the arm and the leg in your patient. Check the tone in the arms usually when the patient is sitting. Check the tone in the legs with the patient supine. I check the leg tone, plantar responses, and heel to shin during the reflex examination when I have the patient lie down. Have the arm move passively and look for signs of tone abnormalities. Either spasticity, where there's a clasp knife type abnormality, rigidity, where the tone is increased through the whole range of motion, or hypotonia. It can be also helpful to rotate at the wrist if you think there might be increased tone, as that's a sensitive way to look for cogwheel rigidity. The screening muscle exam won't take you very much time if you're efficient. You're comparing side to side. Just have the patient follow your directions. Please hold your arms up. Push hard against me. Now make a muscle like this. Pull hard towards you. Pull hard towards you. Push me away. Push me away. Hold your wrists up like this. Keep them up. Keep them up. Spread your fingers wide apart. Push wide apart. Wide apart. And that completes the screening exam of the arms. Now we're checking the lower extremities, once again looking for symmetry. Please put your hands to steady yourself on the bed. Lift this leg up against my hand. Now lift this leg up. Pull your leg back toward you. Pull your heel back here. Straighten your leg out. Straighten this leg out. Cock your feet all the way up. Push up. Push up. Now push down. Push down. And that completes the screening exam. More extensive testing may be needed if you're trying to differentiate between two conditions, such as a cervical radiculopathy or carpal tunnel syndrome. But for the core neurology exam, the muscles we demonstrated were quite sufficient. In checking the sensory screening exam, you need to check for pinprick sensation, vibration, and position. You can either choose your applicator and break it or use a safety pin. I like to use a safety pin as I think the sharpness is more reliable. Start in the feet and then compare to the hands. Does that feel sharp?
Yes.
Does that feel sharp?
Yes.
Are they about the same?
They're the same.
Just place your hands on your lap. Is that sharp?
Yes.
Does it feel about the same?
Yes.
With the tuning fork, if you're doing a screening exam, hit it lightly, or else you'll be waiting a long time for the patient to feel the vibration go away. Does that vibrate?
Yes.
Does that vibrate?
Yes.
Tell me when you feel it go away.
It stopped.
Is it stopped there?
Yes.
Tell me when you feel it go away.
It stopped.
Is it gone there?
Yes.
For a screening test, I would stop with the feet. If you need to compare in the arms, you can move to the arms. If you want to show a gradient of distal loss to proximal after you hit it and the patient says it's gone, then move up to the knee and ask them if they still feel it. That will help demonstrate a gradient. For position sense, you want to make sure you grab the digit on the side. If you grab it on the top, they'll feel the pressure of your fingers moving. Close your eyes now. I'm going to move your toe either up or down. Tell me which way it goes.
Up. Down. Down. Up.
For the screening exam, I'd usually only screen the toes. If there's concern about sensory loss, you may want to do the hands as well. Once again, grab the digit on the side. Keep your eyes closed and tell me which way I move your distal digit, up or down.
Down. Up.
You need patient compliance to do this test well, and sometimes you'll get results that don't make sense. Don't get caught up in it. Don't trust it if you don't feel it's reliable. It's always important to remember the major dermatomes. Patients may be numb in one area if their root is involved. C5 is the lateral aspect of the arm. This is your 6-shooter. C7, C8, T1. T4 is the nipple level, and T10 is the belly button. L4 goes across the knee. L5 is the big toe side. S1 is the little toe side, and the lower sacral roots are in the anal area. Always remember after you've done your sensory exam to throw away your sharp object in the safety box. The next part of the exam is the reflex exam. This is the most reliable part of the exam. There are two major kinds of reflex hammers you may choose to use. The traditional tomahawk reflex hammer, where the flat end is to hit the patient and the pointy end is to hit your own finger as you palpate a tendon, or a round reflex hammer. Choose whichever one's comfortable for you. Remember, if you get the opportunity to check a reflex of a weak muscle, you'll learn something about whether it's an upper or lower motor neuron lesion. I like to start with the biceps reflex because I can palpate the biceps tendon and hit my thumb with my reflex hammer. Once you get a response, hit it as lightly as you need to get a small response, and then compare side to side. Next is the triceps reflex. I try the triceps reflex with the patient's arm in the same position and feel for the contraction. You may have a difficult time getting it that way, so suspend the patient's arm and just hit at the tendon. The tendon is very short, right next to the ulna. Now check the brachioradialis. It's a long tendon in the forearm. Hit it gently and feel and look for the contraction. Compare side to side. Now I have to sit down to check for the knee jerk and ankle jerk. Hit the knee lightly and compare side to side. For the ankle jerk, if you place a little tension on the Achilles tendon but have the patient relax, it will help facilitate the ankle jerk. At this point in the exam, you need to have the patient lie down to check the plantar response. I can't use my usual reflex hammer because of the smooth end, so I use the base of my tuning fork. You could use this edge if you use this type of reflex hammer. Have the patient lie down. When you're checking a plantar response, check from the lateral aspect of the foot inward. Compare side to side. Both toes should be down. Sometimes patients won't tolerate it, and you can write withdrawal in your exam. While the patient's lying down, there are two other things you need to check: tone and heel to shin. Heel to shin, when checked sitting, allows gravity to help. Just grab the leg beneath the knee and have the patient relax. Then pull up quickly. Patients who are spastic will have their foot catch. Compare side to side. If you have doubts, you can shake the foot. It should be loose at the ankle if they're relaxed. For heel to shin, instruct your patient to touch their heel to their knee and slide it in a straight line down the shin, slowly. Try the other leg. That completes the reflex exam.